we're really delighted that Lucy Chappell is able to kind of come and talk to us. Now, normally I'd be going, wow, we've managed to secure a real high-profile celeb to join the conference. Lucy, as I'm sure you're aware, Lucy Chappell's now the chief exec of NIHR and chief advisor to the government. And so that would be a real coup, but actually she's ours. And so we slightly strong-armed her to come and help us, but she wouldn't give her precious time unless she thought this was worthwhile, I'm sure. I can't say anything more about her because she's listening. But I just want to point out that by coincidence, following the last talk, Lucy and I published a paper together on definitions of pre-eclampsia, probably about 25 years ago, sometime last millennium. And I still get to see her every week on a Wednesday, and I can vouch for the fact she's still that very caring clinician who we know and love, and we are absolutely delighted she's able to come and share some of her wisdom with us in APEC. And I know she's a huge supporter of APEC and what we do. And the great thing about Lucy is she's still completely grounded and keeps us grounded. So thank you, Lucy. I know you're busy and we're very grateful.
Thank you very much, Andy. I caught the tail end of that. It sounded like a nice introduction. So I'm Lucy Chappell. I hold a number of roles, as Andy might have said, but I'm Chief Scientific Advisor at DHSC, but have extremely strong allegiance to APEC, as Marcus and Andy know, and very much my sort of first home. I'm going to just talk a little bit about what's happening in Department of Health and Social Care, and also I'm Chief Executive of the National Institute for Health and Care Research. So I'm going to touch on where NIHR is in relation to this field, and then hopefully leave time for some Q&A that can go into that. The sort of the framing of this is that we are still in the early weeks and months of the new government, and therefore not everything is set in stone. So as I go through it, sort of bear that in mind. Let me share my slides, and hopefully you don't get to see my Teams messages, you get to see my slides. So I'm going to assume that's all good. I think we can all recognise that this really is a time of change and opportunity for all of us. And I say that because I think that has come home more now that we have had a change of government, which really brought home that in the final years of an election cycle, it gets harder to do things because of a sort of somewhat inevitable short-termism. So one of the things that we have really seen with the new government is we've shifted our horizons to a 5 and in some years 10-year horizon, and that makes a huge difference for health and health research. Shortly after the new government came in for health, we had our Darzi appointed to do the Darzi investigation, which laid bare perhaps what many of us in the NHS sort of see and know. And one of my roles in the department is to be a Director General looking at, and I have 3 directorates, one of which is the Chief Analyst Directorate, and they did a huge amount of the work in conjunction with the analysts at NHS England. And if you want some quite interesting bedtime reading, then the large technical annex is about the data that we have across the health and care system. Now, inevitably, it cannot cover everything, but actually it shows the power of data, and that if we use data to understand the state of our health and care service, and it gives us a really good view on what we do to change it. I bring up the COVID inquiry because it's very much what I'm involved in at the moment, and it tells us about other drivers to change, where the COVID inquiry is still sort of the COVID pandemic is still fresh for many of us, and it shows us both what is possible with a huge shock to the system, but also where we see some of those challenges. I'm going to talk briefly about the health mission, which is not yet publicly launched, but this is a slide I can show you. which really is about Labour being a mission-led government. There are 5 missions. Health is one of them. The other one that we are crucially feeding into is the growth mission. What has this got to do with this audience? Because we are all part of this. We all need to and want to build a health and social care system fit for the future, and that includes maternity. But we should also recognise that there are many drivers to health and outcomes in pregnancy that exist outside of the maternity services. So I would like to think that we all see both where the direct determinants of health, but also the wider determinants of health make an impact for the pregnant women that we see, but also crucially before pregnancy and after pregnancy. There are 3 goals. The first one is about timely access to the NHS, and really broadly most of the levers for that sit within the health and care system. But actually there's a second and third goal around fewer lives lost to big killers and a fairer Britain, where we really look at how we tackle inequalities, where we actually need the rest of government to be joined up with us and say, often you can have a positive health outcome, but you may also have a positive outcome in another sphere. So, for example, you can take an area like active travel, where you can have an outcome that works for the Department for Transport, but also for health. Children's health is crucial, and as we all know in this audience, children's health starts at least -9 months, but often prior to that. So it's really welcome to see children's health there. The how we do it is the shift. So hospital to the community, analog to digital, and treatment to prevention. And we have to say, how do we make sure that those are not just 3 sound bites, but 3 shifts that we all get behind? Part of this is through an engagement process, which is to ask for wider involvement and input into that health service fit for the future. And so Change NHS is the website where you too can go and put your ideas. Think about what it would mean if we ensured that women's services, maternity, families really made sure their voice was heard. So go onto the website, put your ideas in. That our Secretary of State is serious about how we listen. And again, this will be an opportunity that you may not have for another few years. So let's see how we get lots of voices into that. The autumn budget came 2 weeks ago and has had many ripples. Purely from a health and care research point of view, we were seen to do really well in very, very tight fiscal context. We all know that there's been plenty of commentary on the 22 billion for the health and care service, both for salaries, but also for just keeping up with inflation. But we really do have a real terms increase. It's not a huge one, but we have a substantial budget. It's about 1.6 billion in NIHR. And so we are really key about making sure we are part of that health mission and also part of the growth agenda. The mission of the NIHR has always been to improve the health and wealth of the nation. So this isn't new, but how we do it needs to continue to evolve. This also happens in parallel with a working group that has been going since 2022, post-pandemic, called the Future of UK Clinical Research Delivery, where we really want to continue to ask how do we evolve and sometimes even create revolutions in our clinical research delivery, because it is the sort of the beating heart of how we really drive change for the health and care system. And that's what a lot of people on this call today will be part of. Importantly, it's cross-sector, because the changes that we're talking about are not going to come from a single voice on top. It's only going to come by change. So for all those who hold a position in R&D, whatever it might be, you are part of this and get to feed up through this. It is often enacted through people on the ground, and we should really recognise what they do to keep this going, but also ask, where do we see the appetite for change and reform? So NIHR has chosen to focus around delivering impact, inclusion, innovation, and investment. And we really sort of have gone particularly big on our research inclusion and bringing together quite a few strands of our work. Now, talking to an audience of pregnancy researchers, I hope I can hear you all cheering, because we've battled for years about inclusion, particularly of pregnant women in research. And many of you will know that I've written about it, I've advocated for it for many years. There is a wider point on inclusion, which goes not just into sex and gender, but also into those more widely underrepresented groups. And I think that a community of pregnancy researchers can be really powerful champions for this. We've relaunched our research delivery network on the 1st of October. And we really want to continue to grow clinical research. We don't see ceilings on how much research can happen. And we're also interested in a couple of new areas, such as not everything has to be hospital-centric. There are new digital ways of reaching women and families and children that we should harness. There's also Be Part of Research, which I think in the pregnancy community has got a little less visibility, where we ask people to sign up. You can typically go onto either the website to Be Part of Research, or it's in a rotation, it's on the front page of the NHS app. We're at sort of around 560,000, but we want to get to 1 million and then 2 million, to say this is a way to really democratize participation in research and see how we can make it less. I've talked before about the gatekeeping that can go on. Be Part of Research is a way of getting around that. The average conversion rate is around 11%, as I say, which is pretty, really not bad for going out to a very general audience. But in some of our research, it's a lot higher than that. I pause to say, why research inclusion? Well, it depends who I'm speaking to. So I think there's a really strong scientific case. So I think of research where I've not, the heterogeneity of the population is what gives me some interesting science answers. I understand. Sometimes my next research question comes out of where I've had research inclusion and I don't understand what I'm seeing, so it triggers the next research question. I think there's an economic case when I'm talking to some partners to say, if you want adoption across the UK population, which is incredibly diverse, you should have a representative population in your trial or your research study. And actually, obviously, the moral case, we should be improving access for all. Interestingly, if you look at how you improve outcomes, you'll often improve them to a greater degree by research inclusion, where you see the biggest inequality gaps. And NIHR's got a research inclusion strategy with toolkits to match. So if you are wondering how to do this, go onto our website and say, what would it look like? We're all good at recruiting pregnant women. Are we good at recruiting in a truly inclusive way and in a truly representative way for our pregnant women and more widely? So we've announced that research inclusion will now be a condition of funding. The reason we've done this is that everyone said it's expensive. The committees ask us to write it out. So we're going to change that. So from this autumn, we are making your plans to do research inclusion as part of funding, as if we want to see them, which completely turns it 180. We're also working with the Message Project. Some of you may know I did the Message webinar on Tuesday, which again gives a policy framework, but also gives answers to some really helpful questions in terms of the how. It's not always straightforward, but as some people know, I don't think there's no such thing as a hard to reach group. It's just that we have not tried in the right ways with the right approaches for long enough. And I'm fully aware that some of these areas of work need sustained funding. And I would really do a shout out for APEC as to some of the work they've done on this. And so some of this is also approached through tackling some of our systemic health inequalities. I would like to think that the maternity researcher population was happy to see the maternity inequalities first NIHR challenge launched this year. The reason is that we are clear that we're following the Core 20+5 NHS England initiative, which you can see on the right, and that maternity and the inequalities in outcomes for women of Black, Asian and minority ethnic communities and those from the most deprived groups is stark. And whereas there was quite a lot of funding going towards some of the other areas, that was one of the left behind areas. So that's why we launched the challenge funding. Some of you will be involved in it. Some of you will have further opportunities to get involved with it. Inevitably, we could not fund every application, but we really want this community to get behind this. So the next one is innovation. It won't surprise you to learn that I might talk about PLGF because I happen in my own research career to have seen it really go from bench to bedside, campus to clinic. And that's about innovation in many flavours, but I'm just picking one where we've taken it from a case control study into a cohort study into a randomised controlled trial, Parrot 1 of a single test, and a randomised controlled trial of repeat testing, Parrot 2, very ably led with Andy and with a fantastic number of research fellows in our group. But actually, I'm showing the photo of Marcus in Scotland because it's not enough to publish the research. If you really want to see the impact of innovation, it's about spreading its wings, and the extraordinary Clark's campaign, which Marcus helped spearhead, which has seen eventually agreement to roll out PLGF testing in Scotland. And I show the picture on the right because it's point of care testing, which is coming this way. And why that matters is that it's the global burden of disease of pre-eclampsia. So it's great that we've developed a lab-based test. It's the so what next? And that really refers to saying, if we are going to have maximum impact through innovation, we need to do it through working with industry partners to say, what would a whole blood point of care test look like? So exciting that Andy's group are doing work on this, as are others, to really see that pushed forward in the settings across low and middle income countries where we really see the need for a test like that. There's other innovation. So I've actually just showed, this is the infographic from the BUMP 1 and 2 studies, which Richard McManus led with, which I contributed to. And there's particular interest from our Secretary of State to say, well, show me what wearables can do. So there is a technical challenge with getting wearable cuffless blood pressure monitors going for some really interesting reasons. And so when the BUMP trials published, Marcus was a really key voice in saying, think about what this means for women. So if we showed that it was safe, that women really liked monitoring, we did not have the impact on clinical outcomes that we had anticipated, and if not, why not, and where would this go next? So this sort of overview really focuses on what else do you need to do in this pathway, and where might technology and innovation take us that would really drive a change in outcomes. And where do we also see the opportunity for leapfrogging? We do not have to do everything in a linear sequential way. So leapfrogging in tech is exciting, and particularly some of our partnerships with countries like India, where they often see the opportunities to do exactly that, and a very equitable partnership bi-directionally that promotes that. Investment is crucial in many directions. We have recently, just ahead of this year's spending review, did some economic analysis, which showed that for every £1 invested in health research, society receives over £13 of return. So that's £9 through direct health benefits and around £4.50 in spillover benefits. Now, when I'm in this position making a case to Treasury for a good spending review settlement, these sorts of analyses are crucial, but actually it talks to a wider audience about what are the benefits of health and care research, and how do we count them. So it might feel remote to some of the audience, but actually this is sort of what matters, that drives our further allocations in the spending review, so that we can deliver impactful research. And finally, I come back to impact. How do we demonstrate impact in women's health? Well, we should be thinking, and in fact, this year's NIHR Academy conference, which will be next week, is about saying, put yourself in the shoes of the commissioners, the policy makers, the guideline writers. When you do your research, when you design, deliver, and disseminate your research, how do you get it to actually get into practice? How do you actually get it to make a difference? If you look at what APEC as a patient support group wants, they want to see things changing on the ground for women, and it can really help when we as researchers think about that those audiences. So go and make friends with your nearby commissioners, utilize routes to think about policymakers, and these are a couple of examples both from our NIHR stories page and our NIHR evidence page, which call out sort of where we can make it stick. I often say impact is plural, so what we should stop doing is equally important, and impact through capacity building is also, I think, impact for people is also a crucial part of the concept. So we are doing well at the moment. We have recovered our portfolio across the clinical research network, now renamed the Research Delivery Network. I particularly want to call out reproductive health. Last year, reproductive health and childbirth recruited 237,000. We're going to just put that number in the public domain early next week, and out of 1 million. So the idea that women and families and others recruited within reproductive health and childbirth are slow to come forward is clearly not true, and that's down to the hard work of people on this call and much more widely across the NHR Research Delivery Network. So how can we capitalise on that, and how does that fit into a government agenda to continue to put women's health in the frame, and really through that 10-year plan work that I touched on earlier, to make sure women's voices are heard. So we're doing our bit on offering research to women, including pregnant women, and there is much more that we can keep going on that front. My view is that we also need a well-rounded health research ecosystem. So although you see probably quite a lot in clinical trials, I think there is space for everyone. And I really recognise, in looking at the APEC programme today, the huge breadth and depth of the studies. So rather than just doing what's easy or what's quick or what's large, how do we make sure that we choose to have a rich and diverse portfolio of work in pregnancy, hypertension, maternity and women's health? If you want to know what we're up to, we've published our annual report. It shows the numbers, it shows us more details about all of this work, and because I'm a great believer in putting things out in the public domain. So a few thoughts on next steps. These are not sort of exclusive. These are just some of the areas that I get asked about. Yes, we would like to do a further push on data, and that's both patient data and system level data that will help all of us do our work. We know it's still got treacle in it, and very much on my radar. We know that we need to think about our workforce. As some of you know, I only think of 3 states. You can be research aware, research active or research leader. We have all of these on the call today. And so really interested in thinking about how we get that across the whole of health and care system. So NHS and even more widely, so that everyone can be part of the research efforts. And then settings, and really interested in how we as a sort of pregnancy hypertension community might see delivery of research sort of outside of the hospital clinic, because there's certainly a push on that. And for example, our agile teams in the NHR have done some amazing work with outreach. We know, because we publish our monthly key performance indicators, that some of it's going really well, and we've got some reds, and that's to do with the time it takes to open studies to recruitment and the time of studies recruiting their first participant within 30 days. So I very rarely go out and pretend that everything is absolutely fine. It isn't, but we've achieved some huge greens thanks to the work of many people here, and we're committed to continuing to do that for really every sector of our research community. So I'll finish by saying the 10-year vision that I think I and many of us is that we should really be looking to embed our research and innovation across all of our healthcare system. We know it's better for patients, we know it improves satisfaction, reduces burnout for the workforce, and we know that it really helps us to grow our system into one that more fit for the future. So I hope that gives you an idea of the vision that I've got. Very much see this as women's health and pregnancy research as part of that, and very happy to take some questions. Thank you.
Thank you, Lucy. I'm in Sierra Leone, so forgive me if my connection goes, and we're missing you. 2 things. I mean, please ask questions, anybody. We got Lucy for a few minutes. She has to go shortly. But 2 things I wanted to say. One is, I'm sure being top of the food chain now, people very rarely say well done, but I'm just going to say it because it's phenomenal. And I'm absolutely delighted someone who's a card-carrying academic with your ethos is where you are, and keep going, please. Okay, just to acknowledge how pleased we all are you are in your position. In terms of next, in the pre-eclampsia world, I know NIHR is doing some fantastic bids and support in maternity and focusing and supporting, global stuff as well in the pre-eclampsia. If you're advising the APEC community and the people on this call where you think the buttons should be pushed in research moving forward, what would you say?
Thanks. I think that I would encourage people to go and look at our whole suite of programs. And I know that there will be researchers who are doing that, because we've got many will be familiar with the HTA programme, which funds the clinical trials. But if go and have a look at our Invention for Innovation programme, our I4I programme, or go and look at our HS&DR about health services delivery research, because and our public health research, maternity touches across all of these, and it would be really nice to see us as a community working across the whole space, because for me that gives you that pull through. So wherever your project is at across a pretty broad NIHR remit, that is one area. Broadly, we fund in 4 buckets. We fund our conventional infrastructure, which is areas like our biomedical research centres and our applied research centres, but also our health tech research centres, collaborations. So again, how can we infiltrate the infrastructure so that we're seen as a really key partners, whether it's pregnancy or women's health more generally? The second area is the research delivery network, which I've touched on. The third is our programmes, and as I say, go and look at the full suite of programmes. And the fourth is our capacity building, and we've got really good track record in capacity building in pregnancy research. So go and be curious on our NIHR website. We have done a revamp. It is still difficult to navigate bits of the NIHR, and then also look more widely with partners. So for example, many of our I4I bid grants are with industry partners. We've not had such a track record of commercial research. I am seeing it come much more into pregnancy. If it's about the benefit for the patient, it's got the right outcome. And I think we can see more opportunities there, plus with our charity partners.
Jimmy, I can see your hand. Do you want to come in?
Yes, thank you very much. Thank you, Lucy. That was lovely. And it echo Andy's comments. It is great having you there, because it's not only a sensible, intelligent head running it, but someone who has a background in women's health, which is superb. And what I wanted to ask is that one of the great problems that we see, not only in pregnancy research, but actually research as a whole, is the way people live in silos. And and a lot of the programs that are set up is very silo orientated in a way. And one of the things which we've talked about today is, for instance, the role of pregnancy and the effect of that on long-term cardiovascular risk, for instance, which is an area which I've tried to get people involved and interested in the non-pregnant area for a long time. How can we, and you leading this, help to build the bridges required to get people in the pre-pregnancy medical environment and lead into pregnancy problems, and put pregnancy problems leading into the post-pregnancy medical problems of linking these to proper research and intervention programs?
So as if I'd sort of been completely aligned with you, Jimmy, we've run an NIHR team science camp and stream to exactly address this. So I think there's something that all of us can do, and many of us do already, which is when we craft grants, we explicitly craft them with everyone with a multidisciplinary approach in mind. And certainly it's and we need to sometimes work harder to find people outside our specialty who we think should be represented. And then equally, we need to sort of go and keep on pushing at their doors and say, no. If you're looking at post-pregnancy hypertension, you want one of us there because there are so many determinants in pregnancy. So some of it is done through sort of policy levers and through funders sort of encouraging that through committee review, but some of it, a lot of it is already done organically, as many of you and many others will know, with sort of building those connections and with us rewarding those connections. And certainly we're doing that through some of our infrastructure grants that we have a very high expectation. I would also say that patients and the public are crucial in that, that I think NIHR has really championed that. So it's typically a combination of top down and bottom up, because it's never going to be sort of one or other. It's got to work on both ways. But I would like to think our funding committees really call that out as a strength. And when I was at HTA as the trials chair, we would often say, there's people missing from your grant application, go find them. And this is where particularly you can take an approach of pulling through from what I would call the rising star level. You don't need 12 professors on your grant. We should be supporting the emerging stars as well.
Just got some questions coming through, Lucy. I'm just reading them. This one's about getting NHS systems to talk to each other. have you got any comments about efforts in that area?
Yes, so I am co-sponsor for the Data for R&D programme. It means I don't run it, I sponsor it in the department together with NHS England. The Cathy Sudlow's review, which was launched last Friday, is a very good read. We've been aware that it's coming, it's landed at a particularly good time with the new government, and we have the spending review phase 2, which will cover outer years of this government. So there are already substantial plans through the Data for R&D programme, which has taken us from 7,000 data controllers to 11 through the subnational secure data environments, the SDEs, which is sort of partners the national secure data environment in the NHS. And then there are also links out to other multiple data sources, such as some of the big biobanks and through other areas. So there is both a huge piece of work to do to make that fit for purpose within the NHS England. It is completely crucial that we have public trust, otherwise we can do nothing without that. So one of our completely central pillars is to do that. We have also, as many of you will know, moved from data sharing to data access, and that's a pretty pivotal shift. There is then further work by this government to look at what's called a national data library, which is where we start to join up health data with data in other bits of the system. Again, only possible if we've got very high levels of patient trust and trustworthiness. So more is being done, subject to funding, but with a Secretary of State, including in our department and in our next door department, which is Department for Science, Innovation and Technology, who are with Patrick Vallance as one of the ministers, who's our ex-government chief scientific advisor, who completely understand both the role of data, but also of new technologies such as artificial intelligence, to sort of harness the power of data.
Lucy, I know you've got a hard stop at 1 o'clock, so we'll give you half a minute back of your life, which I suspect is a lot of time for you. Thank you so much. Okay.
Great to be here, and very nice to see the programme of exciting research. Thank you.
All right, take care. Bye.